Thrombosis.TV coverage from the 2015 ISTH conference continues. Joining us now is Dr. Marc Carrier from the University of Ottawa. Thank you, sir, for stopping by.
My pleasure. Thank you for the invitation.
So you've got one of the more exciting events here at this conference. Just get some little props from the New England Journal of Medicine for your late-breaking presentation. Tell us about that.
So for many, many years, clinicians thought that venous thrombosis can be the first sign of an underlying cancer, and it was estimated about 10% of folks with an unexplained venous blood clot, deep vein thrombosis, or pulmonary embolism would have a diagnosis of a cancer within the next 12 months following the diagnosis of their clot. So it's also quite appealing for clinicians to screen for cancer in these patients, because you want to find cancer early and maybe act on it and hopefully increase survival, decrease mortality, and decrease morbidity. And there was clues in the literature that maybe the best bang is in the belly. So there's a lot of literature saying that maybe CAT scan of the abdomen pelvis would be the best screening tool. So we did a randomized controlled trial including 854 patients, randomized to what everybody should be getting in a general population, so basically age and gender specific screening as per US or Canadian recommendations. So in men it would be prostate cancer screening, in women it would be breast and cervical cancer screening. Or randomized to age and gender specific screening with a fancy CAT scan of the abdomen pelvis that included virtual colonoscopy and gastroscopy.
So what stood out about these findings that has created the buzz, if you will?
Right, so we followed these patients for 12 months. The first thing we realized is that the prevalence of occult cancer detection was really low compared to what was previously described, which is reassuring for patients and clinicians, of course. And the second thing is, even if we did extensive screening, there's no difference in the number of cancer detected, in the number of missed cancers, and then all the secondary outcome measures, so including cancer survival, overall survival, time to cancer diagnosis, none of that was significantly different between the two groups. So it more or less say that less is probably more, and that patients, when they have an unprovoked venous blood clot, they no longer need to be too concerned about an underlying cancer. They just need to be sure that they're up to date with their primary practitioner with age and gender specific screening. An extensive screening strategy doesn't do more. Actually, it might do harm, because when you do extensive screening strategy, often you find things that are not related to cancer, incidental finding that needs more investigation, biopsies, complication, costs a lot of money. So we might be causing harm if we do too much.
What do you think the clinical implications of this research are?
So I think, as I mentioned, I think it'll be calming physicians and patients, so reassuring them. More importantly, I think he'll be able to save a lot of scarce healthcare resources, because we no longer need to do additional screening, and therefore we'll be able to focus on other things and then put resources where they should be, or in higher risk population where they should actually get screening.
You used the word calming. This is kind of exciting for you, getting in the New England Journal of Medicine for the first time. What's that like?
It's been a roller coaster all day yesterday, and it's been a fantastic experience for sure. Hopefully I'll be able to publish in the New England Journal again down the road, but you need timing, you need good results, and hopefully that will happen again, but it's been fantastic. Very proud.
As you and I were talking off camera, luck is where preparation meets opportunity.
Exactly.
So we wish you luck and get back to work, all right?
Sounds good.
Thank you
very much.